Sickle cell disease in pregnancy. Pregnancy in the sickle cell disease patient is associated with poor obstetric outcomes for both the mother and her baby. Data from referred centers showed that sickle cell complications during pregnancy leads to high maternal and perinatal mortality. Common pregnancy complications of the mother with sickle cell disease include miscarriages, frequent vaso-occlusive crisis, severe anemia, recurrent urinary tract infections, acute chest syndrome, preterm labor, and pulmonary embolism. In the fetus, complications include intrauterine growth restriction, prematurity, and intrauterine fetal death. Care by a multidisciplinary team consisting of the obstetrician, physician specialist, dermatologist, clinical pharmacist, anesthetist, nurse and midwife ensures good health outcomes for these patients. Causes: inheritance of two abnormal hemoglobin genes from both parents, at least one of which is an S. Crises are typically precipitated by cold weather, dehydration, infection, physical exertion, and mental stress. The signs that are usually elicited are pallor, jaundice, hepatomegaly, splenomegaly, that may be absent in older patients, old or recurrent scarification marks by traditional healers, particularly over the abdominal wall and joints, and also venous ulcers, bruising, espousing, dactylitis, hand and foot syndrome. That's a dactylitis, natopathy, and growth delay or tall, or even lanky stature as malphanoid habitus. The investigations are cycling tests and hemoglobin electrophoresis, full blood counts, including reticulocyte counts, RDT or blood film for malaria parasites, midstream urine for culture sensitivity at booking and whenever indicated. Also, renal function tests, BUN, creatinine and electrolytes, liver function tests, serum iron, TIBC and ferritin if possible, no other antenatal screening tests. Treatment objectives. The main treatment objectives are to identify patients with conditions with a condition early during pregnancy for closer monitoring, and also to correct anemia, to prevent known crisis triggers, to detect and manage promptly or associated complications and crises, also to deliver clients safely as soon as baby is viable. Non-pharmacological treatment. For pre-pregnancy care, you provide genetic counseling, assist patients to plan pregnancy in a status of optimum health, educate on potential risk and health problems of sickle cell disease in pregnancy. Care during pregnancy. So at booking, you assess the patient carefully for risk of frequent crisis and previous obstetric complications. Also examine for nutritional status, anemia, jaundice, and hepatosplenomegaly. Perform ultrasound to date pregnancy and exclude fetal abnormality and growth retardation. So perform the listed investigations to screen for and detect complications. Manage identified problems at booking, for example, urinary tract infection, malaria, among others, appropriately and promptly. For follow-up visits, if low risk, you schedule follow-up visits monthly until second trimester, and then 2 weekly until 28th week, and thereafter weekly. If high risk, you schedule visits 2 weekly until third trimester, and then weekly until term. At review visits, you inquire about maternal well-being, symptoms of crisis, infection and fetal activity. Examine for pallor, jaundice, fever and proteinuria. and check for fetal growth and compare to gestational age. Labor and delivery. The stress and pain of labor and delivery can trigger crisis. Risk of crisis is increased if dehydration, fever, infection, hypothermia occur or develop during labor. So care during labor or delivery is targeted at preventing these triggers. And all women with sickle cell disease must deliver in hospital, and the most experienced midwife and obstetrician should be involved in their care. In uncomplicated pregnancies, spontaneous vaginal delivery must be aimed at until 40 weeks, that's 10, and induction must be undertaken only if the woman has not delivered after this time. So, for the high risk women with recurrent complications, deliver as soon as the baby is viable. At admission in labor should be monitored closely with pathograph. You check for hemoglobin level. You group and cross match a unit of blood on standby, and maintain good hydration with IV fluids. You provide adequate pain relief and provide prophylactic antibiotics. Vaginal delivery should be aimed unless there are obstetric reasons for cesarean section. Prolonged second stage labor should be avoided by offering assisted delivery, as vacuum delivery, and active management of third stage of labor as AMTSL is recommended to prevent BPH as postpartum hemorrhage. So for postpartum care, all sickle cell disease patients must be hospitalized and monitored closely for at least 72 hours postpartum. You check for pallor, puerperal sepsis, acute chest syndrome, vaso-occlusive crisis, and urinary tract infection. You continue with prophylactic antibiotics for at least 72 hours postpartum. You counsel women and their support persons to avoid crisis triggers such as stress, pain, lack of sleep, and fatigue. Encourage early ambulation, especially after operative delivery, and review clients at 7 days postpartum and thereafter weekly until 6 weeks, and refer patient to physician for continuing care. You counsel on family planning and after contraception. For the baby should be screened for sickle cell disease and closely monitor the babies with associated complications, for example, IUGR and prematurity. Sickling crisis and pregnancy. So you admit all sickle cell patients with sickling or obstetric complications during pregnancy to a hospital. Avoid NSAIDs, as well as steroidal anti-inflammatory drugs, for example, diclofenac in the third trimester. Opioids like betadine and morphine for pain management should be used with care during labor due to respiration depression effects on the baby. Identify and treat underlying triggers, for example, UTI, malaria, dehydration, among others. Blood transfusion is recommended if hemoglobin level is less than 7 grams per deciliter at 36 weeks or during crisis. And if in vaso-occlusive crisis, maintain hydration with IV fluids as crystalloid is 2 to 4 liters in 24 hours. And provide anesthesia. The acute chest syndrome, fetal monitoring is essential during this crisis. So pharmacological treatment. You give antenatal treatments appropriately, and also you could give multivitamin oral once daily. For antibiotic prophylaxis in labor and puerperium, you give ceftriaxone IV or IM 1 gram daily for 72 hours, or amoxicillin clavulanic acid IV 1.2 grams start, then amoxicillin clavulanic acid oral 625 milligrams 12 hourly for 72 hours. So referral criteria: all patients with sickle cell disease and also with obstetric complications should be referred to a specialist for continuing care.